So let me just do a brief overview. Why are we going to learn about theory? Three reasons why I think it's helpful to learn theory, because in school we learn about all this nutrition education stuff, nutrition knowledge. We want to give all the information to our patients, but sometimes our patient aren't ready to make those changes. And so part of our job as a healthcare professional is not to convince them, but to find what works for them and collaborate in making a plan. So for me, I think it's important to learn about theory because programs and interventions are more successful. And that's why we do what we do, right? We help people live healthier. We help them be successful with their health. And so next thing is it provides structure and guidance. As much as we're talking about organic talking, it's nice to have like guardrails up and to kind of see like what works, what hasn't worked. And as I mentioned yesterday a little bit, is sometimes it is hard in Native communities to be an evidence-based dietitian, because sometimes you don't know what kind of interventions work in our communities, right? It's like because there's no evidence. And so some of it is, yeah, evidence-based information, but the other one is just using your experience and understanding what works. In the past 10 years, there has definitely been a lot more push to have more research done in communities, specifically around nutrition education, but we definitely need more. So that's why I like, it provides structure and guidance. It also helps us understand our community and our people a little bit more. It's sometimes people get labeled as non-compliant or non-adherent, but there's reasons behind that. They're motivated for something else. Maybe it doesn't align with your values, but they're prioritizing something else. And it's probably more important than nutrition, honestly, as a dietitian. I will be the first to admit that. Sometimes there are higher priorities. All right, so something's going on. My clicker has stopped clicking. Okay. So two different types of theories. So I have a master's in public health too. My master's was community health education. That was the focus. And so these are kind of basic things we learned as public health professionals, two types of theories. One is an explanatory theory, meaning it just explains what people do. It's like, okay, that's why people do what they do. I mean, this is how, different motivations work. And it also explains why people don't do things. And it also can describe community assets and resources. And we'll get into those specific names. I won't go into it specifically because I want to get to the activity. Because this is just like, knowing explanatory theories is nice because you're like, oh, okay, that makes sense now. But sometimes it's not always helpful to know it when you're trying to look at behavior change theories. So behavior change theories, it actually identifies strategies and ways to influence and change behavior. And it also can aid in developing specific interventions. So if sometimes, public health education programs, they want to focus on education. They want to focus on portion sizes, or this food is high in vitamin C, this food is high in vitamin D. But, it's just because the education is out there doesn't mean people are actually going to apply it at home. And so the behavior change theories is like, okay, how do we help people make roadmaps and apply it at home? All right, so these are the 4 main public health explanatory models. Can I get a raise of hands? Who's heard of at least one of these? The health belief model. Okay, we got a few in the back. Trans-theoretical models, sometimes they call it stages of change. Okay, social cognitive theory. Anybody there? Okay, about 10% of the room. Social ecological model. Okay, a lot of us public health nerds, it's all about the social ecological model because it goes from like individual to policy. So these kind of help us understand what we do, and it kind of helps us understand what is our role in developing programs, in developing strategies. I won't go into this much. Last year I did, and it was a lot, and I want to get into the discussion card stuff first. But definitely, if you have time and you're just curious, you can always YouTube these names. But the point is, when we move into behavior change theories, how do we use theory to help change behaviors? And how do we help our community? And for me, helping our community means slowing down. Sometimes we want to give all the information out because we went to school for it for 6, 8, 10 years, and we're so excited to share our knowledge. And a patient comes in and we tell them, oh, you need to do this, you need to do that, you need to do that, you need to eat more non-starchy vegetables, you need to add more fiber, you need to eat more protein, you need to reduce sugar, you need to work out 150 minutes per week, you need to stop smoking, you need to, all these things, right? That's exactly how patients feel when they come into the hospital. Who can do that starting today? Raise a hands. None of us, right? Not even me. And so that means, our community, they come in, they get overwhelmed, makes them confused. It makes them tired. It makes them hurt. Maybe they don't feel like their needs are being met. And ultimately, we have to come to terms that we're all just people living our human lives, and we're all just trying to interact with each other. We're not perfect as public health professionals, right? And so we shouldn't expect our patients to be perfect. So our job is to slow down and understand our community's lives. And again, thinking about sometimes when we're talking about nutrition education, sometimes we, as healthcare professionals, we write patient is non-adherent to diet. I don't know what that means, but it's like, no. Like, let's not label people. Like, I don't know what that means, and what your definition of adherent is, because your definition of adherent is probably different than what your patient thinks it is. So the goal is to look at patient resistant in a different way. And it's to move them from my patient is not motivated. Sometimes I've seen that in chart notes. Move it to is my patient is motivated for different things. And so this is actually a pretty common saying, especially for people who have trained in motivational interviewing. And this is where I get a lot of my own knowledge from, is through motivational interviewing. That's how I do a lot of my own counseling. And so I did want to bring up the writing reflex. This is another motivational interviewing term. Show of hands, who's heard of writing reflex? Okay, we got 3 people. So all of you guys are fresh babies. So the writing reflex. So this is kind of a phenomenon where, remember, we know all the knowledge and we want to give all the knowledge to everybody, and then automatically go into policing people's choices. And this policing of people's choices, that's what we call the writing reflex. So this lady, she has her ruler out, and you say, okay, you're drinking energy drinks, slap. Don't do that. That's the writing reflex. So understanding that people doing this, they say, I know exactly what will work for you. I know the solution. If you keep doing this, you're going to end up worse. So threatening people, that's the writing reflex. Another version of it is, if you only listen to me, then you wouldn't be in this situation. I often heard that in an ICU setting, and I would hear providers say that. I told you to stop drinking that soda. Now you're getting your leg cut off. That's kind of messed up. And then last one is, why can't you just listen to me? What's so hard about it? Why is it so hard to eat vegetables? Anybody can do it, and I doubt they're doing it. So it's very much this concept of like, I know best. So you better listen to me. And historically, that's how the healthcare profession has been, is it's always been the doctor, the nurse, the dietitian, the physical therapist. They're the ones in power. The patient is the one that just needs to sit there and be like, thank you, and listen, and then go home and do everything that the doctor says. But that doesn't work, and it hasn't worked historically. Some patients in my community, they don't want to go back to the hospital because they know that they're going to get chewed out by their providers. And as dietitians, we have that stereotype. Nobody wants to come to me because they're all scared to talk about they had Burger King last night. And so this is something I'm trying to actively fight against as a dietitian. I'm not that lady with the ruler. So again, another principle of motivational interviewing is leading through curiosity. And the way we do that is through an acronym called RULE. It's called, R stands for resist the writing reflex. So that's the lady, just stop telling people what to do. Next is understand a person's motivations, understand why. Why do they feel like they need to drink soda instead of water? There's a reason behind that. Maybe they feel like their water's not safe. Listen with empathy, try to put yourself in their shoes. And that's something I see a lot of, that as providers, we're already in a privileged position. I don't think there's a lot of providers who are food insecure, but sometimes we project that privilege onto our patients and we think, well, just because I can afford these vegetables, that means everybody else can afford it. So we have to take a step back and be a little bit more empathetic towards this person's situation. And then last thing is empower the patient. Once you kind of understand all of these RULE or RUL, then that's when we can move forward. When patients feel heard, when they trust you, when they feel safe, they're more likely to kind of be like, hey, I think this can work for me. So again, leading with curiosity is important. So when we're going through, again, in my technique, when a person comes in and they're like, I can't do this, I don't know how to change my habits, I don't want to do it, I'm fine the way I am, we kind of call that starting with the resistance end of things. And the goal is to kind of move them through all of these different stages. So how there's the, what are those stages of grief? Who's heard of stages of grief? I don't know what the stages are, but I know it's like acceptance and something else. Anger, acceptance, denial, bargaining. Pretty sure we're saying it out of order, but anyway, it's out there. But this is kind of like that, where you're moving through different stages with the person. And people can be in different stages. So they can be resistant, they can be ambivalent, they can, like thinking about it. They can start to understand what's going on. That understanding can lead to pursuing options, looking at all the options. And then look, behavior change. That's how we get them to it. All right, so now quick multiple choice quiz. Which of the following are the 4 guiding principles of motivational interviewing? How many people have answered? Okay. And the Zoomies can join in with us on here. So first multiple choice is recognize challenges, understand completely, lead the person, empower the person. B, resist the writing reflex, understand motivations, listen with empathy, and empower the person. C, respect authority, utilize motivation, learn, encourage the person. D, reflect with care, urge the person, listen with empathy, and evaluate readiness. I'll choose my answer. So we got 30 people who have answered so far, 33. All right. It looks like we got a good amount of people who said the right answer, which is B. Resist the writing reflex, understand motivations, listen with empathy, empower the person. So yay, you guys learned something. um, all right, so let's go into it. Patient, again, all of this is leading to um, supporting patient autonomy. So important is especially for Native communities because often Native communities, they may not feel empowered. Native people may not feel empowered in their healthcare. And so one way to help them feel empowered is to support, to let them know you're in the driver's seat. I am just here to help you along, give you ideas. Let's see where we can go. Because remember, health is not one size fits all. There's many different ways to managing certain conditions. We just have to find the right one. That's where all of our knowledge comes into place, is not to word vomit everything. It's to selectively think about, okay, how can I provide this knowledge in an opportunistic way when they're ready? And so it leads to informed decision making, leads to collaborative goal setting. We need to personalize interventions. It's a respect for choice. It's about motivation and ownership. If they don't have any skin in the game, like they're just gonna keep doing what they're doing. And then also it's a really big ethical consideration, right? It's not ethical to go in and tell people what to do. We need to help the patient realize their potential. And ultimately for me, it's about the person is the expert in their own lives. I have no idea about what obligations this person has. Maybe there's 3 grandchildren at home, 5 children, one is disabled, they don't have running water. I never lived that life. So how am I going to be like, I know the best solution for you? And so person's the expert in their own lives. So our job is for us, the way we move towards behavior change is understand their desire. So, what do they hope to achieve? What is their health goal? Maybe it's to lower their A1C, maybe it's to lower their blood pressure, maybe it's to get their HDLs up, maybe it's to lower their LDLs, maybe it's to make sure they're not be turning hyperkalemic, eating too many high potassium foods if they're on dialysis, many different ways, or many different things people can be moving towards. And then it's also our job to look at ability. What are they capable of? Do they know how to cook? Do they know how to chop vegetables? I've met a lot of people who don't know how to cut garlic. And I'm not saying like you have to know how to cut garlic, but it's still surprising. And I used to live with my aunt and I would cook with garlic and she'd be like, this tastes really good. And I'm like, it's just garlic. So some people don't have that ability. Some people are not able-bodied. Some people rely on other people to perform their ADLs. And so we need to be aware of that. And then the third thing is reason. We need to understand why are they doing this? Is it because they want to see their kids' graduation? Is it because they want to be an active parent when they're playing with their kids? Is it because they want to, I don't know, hike somewhere with friends or go on a camping trip with friends? Everybody has different reasons. And then next is need. Again, that kind of goes hand in hand with reasons, like maybe there's a need out there you want to cover. Maybe they don't want to have complications that their family member had. And so they feel like they need to manage this condition so that they don't run into those complications. And then finally, when we kind of elicit all of those things out of them, that's when we can be like, okay, what can you commit to? Like, what are you ready to try? Um, and that's the tricky part. And, there's like SMART goal settings we could try. But sometimes people are like, this is too specific. Or it kind of hits people in the face where they're like, I just came just to learn about vegetables. And I'm like, how many vegetables are you going to eat per week? And they're like, whoa, whoa, whoa. So commitment is the tricky part because people get a little weirded out with that. And that's where we look at behavior change. And that's where we can follow up with them and say like, hey, how are you doing with this? Um, so this is something I like to do. And P4 program will recognize this slide because I use it with some of my cooking classes. Because it's not enough for us to say bell peppers have high vitamin C and they're heart healthy foods. And then nothing goes on from there. With all of my cooking classes, I say, this knowledge, it's not just like a nice to know. There's a reason why I'm talking about this. The reason is to help you think about how we can incorporate these foods into what you eat at home. And so I usually have like worksheets for people during my cooking classes. And I say, while we're cooking, think about how you want to include whatever we're cooking. And so I have them fill this out in which they will write down, I will eat and enjoy. That's very important. I don't want you eating Brussels sprouts. If you hate Brussels sprouts, find another vegetable you like. I will eat and enjoy blank food for how many times per day, per week, per month? I don't know, maybe just this month. With counseling, I would say we would get to this goal setting and I would say like, how long do you want to do this for? And then they'd be like, I don't know, for the rest of my life. And I'm like, that sounds like a pretty big goal, little intimidating. Let's see if we can put it into bite-sized pieces and say, what about just for this week? Do you think that's doable? And it kind of makes it a little bit more tangible and realistic instead of me saying, for the next 60 years, I'm going to eat a bell pepper each week. Like that sounds really intimidating, right? And so just helping them kind of like, envision how they can incorporate that food or whatever behavior they're doing into their life. And then following up with, and I will do this for, well, I already answered that. How long will he do this for? 1 month, 1 week, whatever. So what was being passed around for you guys is I developed a discussion card deck specifically designed for dietitians, but you can take a look at it. I'll explain it in a few more slides, but this worksheet right here is a SMART Goals worksheet. If or when your patient is ready, you really have to build trust before you pull this out because people are like, whoa, like, take it easy there. I just came because my doctor told me to come, So SMART Goals worksheets, I developed a bunch of handouts and the discussion card deck to help kind of facilitate this process. So hopefully by the end, we're going to get to creating behavior change goals. So there's also this other thing called the importance ruler. Who's heard of the importance ruler? Raise your hand. We've got like a few people. Okay, like 10 people maybe. So when we create a goal with a person, they're saying, I'm gonna eat a serving of carrots with my dinner twice this week for the next month. And then I ask them, okay, on a scale of 1 to 10, how important is this to you? 1 being not important at all, I don't care about it. 10 being, it is very important for me to eat 2 servings of carrots every week for the next 4 weeks. And because, some people will be like, well, I guess it wasn't important. Then you'd have to back up and be like, okay, let's look for a goal that's actually important to you. Because if it's not important to them, they aren't going to prioritize it. Because remember, everybody has different priorities. Everybody in this room has different priorities. I have different priorities than you guys. And it's not always, I'm going to eat vegetables today. And so just assessing that, that's just kind of like a quick, getting a quick primer on like where they're at. The next one is called the confidence roller. So the confidence roller goes, you can tell, let's say they set a goal, I'm gonna eat 2 servings of carrots this week and for the next 4 weeks. And then you ask them, how doable or how confident are you in this goal? And sometimes that's kind of a harder question. So you guys can find your own wording and that works for your community. Because that's when I started implementing these 2 tools, people would be like, what are you talking about? Like, it sounds like a survey. So you can find your own way to convey it in your own community. I said, how much do you think, sometimes I'd say like, how much do you think you'd be able to do this for? Or how easy do you think this is gonna be? That's another way of asking it. It's not really on a scale of 1 to 10, but that's a different way of asking it. So whatever works for you. So now we're getting into the activity portion. So what I'm going to say, we have an activity called a discussion card deck. It has 16 topics. One goes through different topics: no electricity or water, on the go, frozen, canned, or dried foods, try new foods, meal planning, budget friendly, traditional foods, recent lab work, including family, difficulty chewing or swallowing, emotional and mindful eating, medication and interaction, snacking, favorite foods, eating out, and other. So I developed this because sometimes when I ask people like, well, what do you want to learn today? What do you want to get out of this visit? And then people are like, I don't know, my doctor just told me. And it's like, it's hard to go from there. And so sometimes, yesterday I was talking a lot about, many of our communities are visual learners. And so I like to use these pictures to show, I spread it out in front of them and I show them, which one do you think is most important to talk about for you? And that way it gives them a little bit more of some visual cues. Some people will say, well, I want to talk about traditional foods, or I want to talk about my last A1C, which one of them is like recent lab work, or it could be like some crazy ball other thing, random thing that their cousin brought up the other day. It could be the carnivore diet. And they have questions about it. And so this kind of makes things, puts things out on an equal playing field and saying like, okay, these are all of your options. Which one do you think is helpful to you to learn more about? And so back to the activity, meet Michael. Michael was recently diagnosed with kidney failure, supposed to say kidney failure, and he's on dialysis now. He was informed he needs to eat a dialysis diet. He met with his nephrologist and his diabetes educator. He was referred to see a dietitian and he scheduled an appointment. So he tells you, he shows up to the appointment and he tells you the diet, you guys are all pretending to be dietitians here. He wants to stay healthy as long as he can for his wife and his grandkids. And he also wants to stay healthy so he can help around the house, so he can chop wood. So he's not sure how to eat in a way that supports his desire to stay healthy. So if you don't know, if you're not a dietitian, dialysis diet, the things that we focus on is sodium, making sure we're restricting sodium, making sure that we're eating enough protein. That's very important for people who have diabetes or on dialysis. And then potassium is the other electrolyte that we're watching out for, because if his potassium levels get too high, it can affect his heart. And then the other one is phosphorus. If his phosphorus gets too high, that can also cause other complications. So that's just brief primer on dialysis diet. So he, wants to stay healthy, but he gets confused because he's getting conflicting information from all these different healthcare providers. And so now where do we go from here? Give him flowers. So I like to imagine, here's your flowers, but what you're giving him is options. Each flower is an option. Each option is on one of these cards. And so these cards are meant to be a little bit more flexible. So it's not condition specific. They're just kind of meant to kind of give you nudge, nudge. So on the back, okay, let's see. Michael says he has no electricity or water. How is that going to affect his dialysis diet? So on the back side are kind of like prompts or things you could possibly talk about. You don't have to talk about them all. These are just like gentle suggestions about what you may talk about. So some of the key messages you might want to talk about food security. Maybe you could do a screener, see if he's able to get enough food. You can ask about that he always has an option to not focus on increasing nutrition if securing food is the main priority. Sometimes people feel very shamed because they can't afford food and they're on a dialysis diet, and just reassuring him, like, I know you have a lot going on and it's okay. And I just want to make sure that you have enough food. That's it. The other one is if the person chooses, we can still make some steps to eat nutritious food. So if he's like, okay, I still want to know what I can buy. So it's important for us to not shame him. And then we ask him like how and where food is typically stored. We could possibly discuss food safety, especially for somebody who's is on dialysis. They're a little bit more immune suppressed. And then we could also talk about the non-perishable grocery shopping list. So when you see that asterisk after the sentence, that means that there's an accompanying handout. So there's several handouts, like a grocery shopping list, the SMART goal worksheet. I don't know what else is on there. I don't know what I made. There's the hunger and fullness scale. There's the healthy snack framework. There's a healthy family checklist. And then just counseling tips, which is the OARS, which is another motivational interviewing tactic. So that's kind of how this was designed, was to help guide these conversations. There's many different options we can pursue. Not, maybe not on here too, but these kind of address some of the same issues as what patients can prioritize. So it could prioritize the meter if they have diabetes, or a blood pressure cuff if they have one at home, exercise, medications, maybe care coordination. That's actually not in here, so that would be like an other. And then food. But again, you have to use your active listening skills to kind of understand where are they coming from. Okay. So we already went over, oh, I guess I jumped ahead, but we already went over the card deck. Provides those menu of options, reinforces patient autonomy, can be used to help scale a person's importance. So if you lay this out in front of everybody and you say, what are the top 3 things you want to talk about? Automatically, that's telling you what's important to them. So then that way you don't have to be like, what's the most important thing to you in nutrition? And that's too open-ended. And again, sometimes we need those guardrails for patients to understand what we're trying to get at in a non-judgmental way. And again, after, let's say you set a SMART goal based on one of these topics, and you can assess the confidence after. So let's get into the activity. Let's see, we could do one. So if we want to get into groups of 3, one person is going to be Michael. So remember, Michael is on the dialysis diet. He's asking questions, wants to make sure he's there for his family. And Michael is going to, so it's a role-playing activity. Michael has this issue going on. One person is going to be the provider, so you could be the dietitian maybe. And then we have another person who's sitting from the outside observing the interaction. And so the goal is for Michael or the provider to start the conversation, lay out all the cards in front of that person, and ask them to choose some of those more important things that you, Michael, would think he would choose. So you can ask, for the provider, you can ask things like, what's your biggest concern when it comes to these topics? What made you choose these 3 topics? What would you want to make, why would you want to make this change? And then ask them, if you decided to make this change, how might you go about it in order to succeed? You can use your own wording, like you're just asking, like, what do you plan to do? If he's stumped, like sometimes people, they do get stumped. They just don't know how to answer. They don't know how to make a plan. What you can do as a provider is say, is it okay if I go over options that you can try or strategies? Or what I like to do, yesterday I talked about putting things in third person. I like to do that too with this. I say, do you want to know what one of my other patients did who was in your situation? And even though I actually didn't have a patient who was in that situation, I would still say it. I would just be like, oh, I know somebody, they did this. And then that's when I sneak in like my options, my suggestions. And then, so you can ask to offer advice. Remember, don't go straight into, I know what's going to work for you. Ask permission to offer advice. And then once they kind of settle on a SMART goal, so you guys you're trying to help Michael set a SMART goal. And then ask them, what are your top 3 reasons for you to succeed in this goal? So if you have time, I'm not sure if we're going to have time, but you can also assess importance or confidence, use that scale. And then after you've listened carefully to all the answers, give back a short summary of what you've heard of Michael's motivations for change. And then you can ask one more question. So what do you think you'll do? And answer or listen with interest to the answer. And then afterwards, we're just going to have a debrief. So we have the 3 people who are in the different roles. And then we're going to ask just your thoughts on that whole interaction based on each role. So if we can do like, how much? 5 minutes? Is that enough time? 10 minutes? Like 10 minutes? Yeah. So I'll set a timer for 10 minutes. Yeah, that's it. Any questions about the activity? Kind of clear, sort of clear? Good? Ready, set, go? So go ahead and introduce yourself or your role. So say, I'm Michael. This is how it felt doing the discussion card activity, or I'm the provider. This is how it felt doing the discussion activity. The role or the observer, tell us about your experience too, and say like, this is what I noticed was going on. Yeah, that's how it's going to go. So which group wants to volunteer? That way.
Well, I'm Michael, and when I went to my appointment with my dietitian, she was very friendly and welcoming, allowed me to express some of my concerns and fears. My biggest thing is that I don't have good teeth and I can afford my dentures. And I also had to travel a lot for work. So, and I was provided with new medication where I don't really understand a lot of the interactions. And so she provided a list of things and also provided resources for dental that I might be able to get them so I can eat. My biggest protein is meat, but I can't show it. So she gave me another list of things that I can have. Also, since I had to travel and don't know what to eat, and I'm spending a lot of money buying food at the convenience store, she also assists me with the critical thinking. What are the things that I can change today that I can help me to improve my health? And that was the creation of healthy snacks. And we navigated that. So I felt very empowered, and hopefully I get to have my dentures coming up soon.
Yay,
Thank you.
Michael. So give her a hand. All right, now we have Michael's provider. How did it feel with the whole activity?
I think the cards were very helpful, especially when someone might come to an appointment with not knowing what they want to discuss. I think it was helpful to have it all laid out and facilitate the conversation a lot easier. I'm not a dietitian, but I do goal setting with families, and I can see how this could be applicable.
And what do you do?
I work for Colorado State University with a family wellness program, but we teach habits like related to nutrition and physical activity, and the parents have to set goals for the 6 weeks that they're with us, and they do a weekly goal and an end of program goal, and a lot of people come not having an idea of where to start, and so something similar to this would be really helpful in our program just to get the conversation started.
Yeah. All right, observer. What did you notice about the dynamic?
I thought it was very like a very calm interaction, which I really appreciated because in situations like for Michael in this case, I would be really nervous and just like I don't know where to start. And Michael was also very calm and very understanding. But yeah, I agree with the cards. They're very, very helpful. I really appreciated at the end. You mentioned a lot about follow-ups, and yeah, it's definitely very, it's comforting to know like always or not the constant check-in, but just check-ins, regular check-ins with patients pretty much. So
Okay,
yeah.
thank you.
Thank
Thank
you.
you, observer. Give her a hand. All right, so what time do we have? We have like, do we want to do one more group or are we good? We want to do one more group? Okay, who wants to volunteer their group? Okay, yeah.
I was gonna say you volunteer or I volunteer you.
Since you said one more group,
What?
I volunteer you.
I'm Nora. Hello, hello. Almost to the end. Thank you. I'm Nora and Marcy and I are the observer. This is Michael and this is our provider. And we're going to tell you what happened in our scenario. Yeah. So just do a really quick one. So when Michael came in, he's Navajo speaking. He does not read very much, and he preferred a visual, so the pictures were more applicable to him. The provider did really well as far as like addressing permissive. Can we talk about it? Would it be okay? Michael was just a little hesitant, I felt, because he didn't even understand what dialysis was. And so that took us back. Even though he chose medication as one of the topics, it was really hard to engage him because he still didn't know what dialysis was. And even though I felt like even though the cards were helpful, we picked it up a lot and looked at the back. But Michael was real, I felt, at least in our experience. No family with him. And he was able to tell us what his learning way would be. And we just felt like we were probably gonna look for a diagram of a kidney because he needed to help. We needed to help him understand that. And then looking at the calcium carbonate, all these medicines that are involved with dialysis patient, that was the other thing too. We
All
felt.
right. All right.
He went to one card and not three.
Yeah. Yeah.
Yes.
And 3 honestly can be overwhelming
Overwhelming,
because
yeah.
one topic is
Thank
just
you. It was
overwhelming.
great. Good.
Yeah, yeah, and definitely, that's something that isn't even on the card deck, is just explaining the condition about what's going on, and really explaining that condition can help, and taking a step back and using visuals, that can really help too. So maybe I'll add that to the next iteration of the card deck, is explaining the condition, explaining an organ, because some patients, they think, well, a kidney is the same as the liver, like same thing. Kidney is the same as the lungs in many of our patients' minds. So sometimes it helps to kind of talk about, what does this organ do? What is its job in the body? Kidneys filter, liver like transports and stores things. So sometimes people, they do need to talk about anatomy, and it's just like us, right? That's how we learned in the healthcare professional setting. We learned about what every organ did. And it's like, well, why are we just expecting our patients to already know what this organ does when we ourselves had to learn what that organ does? So, all right. Well, thank you. Next slide. Mouse is over here. All right, so in conclusion, thank you so much, everybody, for spending your time and energy with us these past 2 days. I hope that some of these takeaways for you is that understanding that Native history, beliefs, and relationship to the patient and health is paramount. I hope you also took away that actively listening builds trust with our patients. And then also understanding that blending Indigenous knowledge with evidence-based messages is necessary to providing inclusive care. And ultimately, my goal is that Native communities deserve healthcare with love, dignity, and compassion. So thank you. Yeah. All right, and thanks. And this is, oops, shoot, sorry. All right, so if you have any other questions, just let me know. But definitely that concludes at least my portion of the presentation. But I'm always happy to talk more if you have more questions. That's it.